Upon completion of this section, you will be able to explain the differences between home care and other specific healthcare delivery systems, list and describe the requirements for home care service provisions, and identify the service provisions which limit the agency's ability to provide care. Caring for the ill is achieved in a variety of settings. Acute care in the hospital, subacute or skilled care in a short-term care facility, extended care in a long-term care facility, ambulatory care in an outpatient or clinic setting, and home care. What sets home care apart from those other settings is the involvement of the patient support system in the patient's plan of care. Members of that support system, who may be family, friends, or hired attendants, learn and share in the rewarding practice of caring and healing. Due to the aging of the American population and the high cost of hospitalizations, care for the sick in the home setting is an increasingly popular and often necessary choice. As in the hospital environment, providing health care in the home has its own challenges, rewards, and responsibilities. The hospital includes within its walls many services and departments used by healthcare professionals to deliver optimum care to patients. In home care, however, the controlled environment of the hospital is gone. The healthcare provider in the field is no longer surrounded by other knowledgeable staff, nor with the variety of accessible equipment. This autonomy and independence in home care demands critical thinking and the ability to make independent judgments concerning patient care. To do their jobs well, home care providers need a broad understanding of patient care, as well as an in-depth knowledge of a particular discipline. Home care field staff must have respect for people and their lifestyles, willingness to accept change, and a desire to learn from others. Home care requires practical skills, such as safe driving, time management, clear communication, and increasingly, computer literacy. Being at home can speed up the healing process and reduce the risk of infection. Home may mean good food, familiar surroundings and routines, and family caregiver involvement. In certain situations, home health patients may even return to work or school. However, the home environment can also present challenges for the healing process. Barriers to optimal patient care in the home include no willing or able caregiver, deficient financial resources, and an unsafe home environment. The goal of every home care provider is to deliver the best available skilled care on a short-term, intermittent basis. The expectation is that the patients and caregivers learn to perform many duties of care in the home under the direction of the home care professional. Once those skills are learned and independence is achieved, the patient is discharged from home care service to be followed by their physician or in a clinic setting. The provider in home care offers what is referred to as a skilled service. That is, must be done by a person with specific skills, such as a registered nurse, physical therapist, speech therapist, or occupational therapist. The planned duration is short-term, for a predetermined brief period of time, and intermittent, in a limited number of encounters between the provider and the patient and caregiver. Some insurance companies state how many visits will be given to a patient based on the patient's diagnosis. For example, a patient needing diabetic teaching may be authorized for 6 visits over a 2-week period. This means the nurse uses his or her skill in that time period to make the patient or caregiver independent in diabetic care. This burden on the healthcare professional to teach those in the home the skills needed to achieve independence is a primary responsibility of patient care. Therefore, it is imperative that those in home care have a thorough understanding of home care limitations and the business of home care governed by insurance regulations. The plan of care is often designed by the home care provider in collaboration with physicians. Consequently, the providers play a direct role in deciding how a patient's medical benefit insurance money is spent. The wise home care provider knows which patients are appropriate for home care and why. The home care industry in this country has evolved into a system directed by federal Medicare insurance and by individual private insurance companies. Currently, Medicare patients comprise the greatest number of home care patients. As a result, Medicare regulations determine what patients are admitted to home care, what services those patients receive, and how their medical information is processed. For purposes of this video, Medicare A regulations will be used to explain home care regulations, as governing the care of adult patients in home health. Administration and monitoring of home health care is the province of many regulators, licensors, and surveyors. The very large role Medicare and other insurance carriers play in home care has already been mentioned. These insurance organizations not only pay for a large part of care delivered in the home, they may also direct to whom and how the care is delivered. In addition to the requirements of OASIS and HIPAA, regulators, licensors, and surveyors include CMS, the Center for Medicare and Medicaid Services, OSHA, Occupational Safety and Health Administration, accrediting bodies such as JCAHO, Joint Commission on Accreditation of Healthcare Organizations, or CHAP, Community Health Accreditation Program. State licensing bodies, such as state departments of health. To receive Medicare reimbursement and be labeled Medicare certified, home care agencies must comply with Medicare conditions of participation and with the service criteria requirements of the Health Insurance Manual referred to as HIM 11. The conditions of participation include the following. The patient is an eligible Medicare beneficiary. The home health agency has a valid agreement to participate in the Medicare program. The beneficiary qualifies for home health services. The services for which payment is claimed are covered. Medicare is the appropriate payor. The services are not otherwise excluded. The patient is to be informed of his or her rights, and the home health agency must protect and promote exercising them. The agency must collect OASIS data and report that data to their state survey agency. HIM 11 requires that to obtain reimbursement for all services provided to a patient, a physician's signature authorizing that treatment be obtained by the agency, and that standardized data collection forms be completed accurately and submitted in a timely manner. Occupational Safety and Health Administration, or OSHA requirements, address situations that impact employees in any workplace, including a home care agency. Specific areas of concern for healthcare employees monitored by OSHA are hepatitis B vaccination, tuberculosis monitoring, protection from bloodborne and airborne pathogens, and the use of personal protective equipment. Other concerns addressed by OSHA are standardized precautions for handling body fluids, recording activities related to infection control, safety management, and the management of hazardous and infectious waste.
Her incision looks great, it's healed. There are no signs of infection.
Accrediting organizations such as CHAP and JCAHO are often commissioned to survey a home health agency to assess the extent of that agency's compliance with established standards of care. This validation process is a voluntary one. Although Medicare is home health care's largest and most consistent source of reimbursement, payment methods are changing as it strives for effective cost containment. One of the goals for OASIS automation is to fulfill the provisions of the Balanced Budget Act of 1997. The Balanced Budget Act includes a Medicare requirement for prospective payment that depends on the data acquired by the OASIS system. The Prospective Payment System, or PPS, works much like the DRG system used in hospitals. Reimbursement from Medicare for home care visits and most supplies falls under its Part A coverage. Part B coverage is necessary for infusion therapy, home medical equipment, and some supplies. Medicaid insurance programs observe similar admission criteria and guidelines as Medicare, but serve the indigent. Consequently, Medicaid patients generally do not need to meet the homebound requirement, and services are available to all ages who meet each state's Medicaid eligibility criteria. As the programs are state-run, they vary from state to state. Most services, however, must be authorized prior to being given. Reimbursement by private indemnity insurance and health maintenance organization payers is directly based on the guidelines within the policy held by the patient. The rule of thumb is not to assume anything and ensure that benefits are verified and visit authorization received prior to making the first home visit. What sets home care apart from those other settings is the involvement of the patient's support system in the patient's plan of care. Members of that support system, who may be family, friends, or hired attendants, learn and share in the rewarding practice of caring and healing. The provider in home care offers what is referred to as a skilled service. That is, must be done by a person with specific skills, such as a registered nurse, physical therapist, speech therapist, or occupational therapist. The planned duration is short-term, for a predetermined brief period of time, and intermittent, in a limited number of encounters between the provider and the patient and caregiver. The conditions of participation include the following. The patient is an eligible Medicare beneficiary. The home health agency has a valid agreement to participate in the Medicare program. The beneficiary qualifies for home health services. The services for which payment is claimed are covered. Medicare is the appropriate payor. The services are not otherwise excluded. The patient is to be informed of his or her rights, and the home health agency must protect and promote exercising them. The agency must collect OASIS data and report that data to their state survey agency. Home health is a general term often used to describe any care of a patient at home. However, home health care is often confused with hospice care. The difference between home health and hospice is important due to the regulations and reimbursement that exist for these two modes of care. Home health patients are expected to improve or, at a minimum, stabilize while on the service of the home health department of a home care agency. For that reason, all treatments and services delivered to home health patients are short-term, with the goal of enabling the patient and/or caregiver to be independent in the patient's care. The goal for hospice patients, on the other hand, is to die at home in a pain-free, dignified manner. Hospice patients must have a terminal or life-limiting illness and be expected to live for 6 months or less. The dying patient and the family or caregivers are cared for by a multidisciplinary team that includes doctors, nurses, chaplains, social workers, home health aides, pharmacists, and hospice-trained volunteers. While the concept of home health care may be all-encompassing, the agency itself may be limited in the types of services it provides. For example, if an agency is requested to see a patient receiving intravenous therapy and there are no nurses on staff with infusion therapy skills, the agency should refer the care of that patient to another organization or contract those services through another agency. Some other service limitations that may restrict an agency from delivering care in a community are hours of operation, geographic distances and communications abilities, patient support systems, and appropriate modes of treatment. The goal is for the doctor, the provider, and the patient to understand what limitations, if any, exist to providing thorough round-the-clock availability. An overall rule is that if a patient is receiving hospice care, has a life support device or any kind of tube, such as an intravenous catheter, a gastric tube, or a urinary catheter, assistance must be available around the clock. This assistance may be a visit by an on-call nurse or may be a phone call from a triage center, depending on the condition of the patient and the severity of the patient's problem in the home. Appropriate geographic access is a major factor in providing home care. The patient must live in an area serviced by the agency, at least while the home care is being given. Home care patients must be able to contact each agency providing care. Likewise, medical professionals must be able to connect with the patient. When the anticipated care is extensive and/or frequent, planning for coverage prior to starting home care is vital. Key words here for the caregivers are willing and able. Prior to a patient's admission to home care, decisions should be made related to modes of treatment as determined by the patient's medical condition, the planned length of therapy, and the patient's ability to be safe and comfortable. The agency must have staff trained in the management of various modes of treatment as prescribed by the physician. The rule of thumb is not to assume anything and ensure that benefits are verified and visit authorization received prior to making the first home visit. Home health patients are expected to improve or, at a minimum, stabilize while on the service of the home health department of a home care agency. For that reason, all treatments and services delivered to home health patients are short-term, with the goal of enabling the patient and/or caregiver to be independent in the patient's care. The goal for hospice patients, on the other hand, is to die at home in a pain-free, dignified manner. Hospice patients must have a terminal or life-limiting illness and be expected to live for 6 months or less. Upon completion of this module, you will be able to describe the primary services required for a patient to qualify for Medicare reimbursement, list non-primary services provided by the agency which are covered by Medicare, identify services an agency may provide but are not Medicare reimbursable, identify and describe services that must be provided on the initial home visit, and discuss 2 purposes for the patient's plan of care. Home health care starts with a physician requesting the services of an agency to care for a patient in the home care setting. To be admitted to home care, a patient usually must meet the homebound criteria. The term homebound means the patient has a condition that makes leaving the home a great and taxing effort. The homebound patient may have a medical condition that obviously contraindicates leaving the home. More commonly, however, the homebound patient is restricted in his or her ability to leave the place of residence except with the aid of supportive devices, such as a cane or wheelchair, the use of special transportation, or the help of another person. Once the order is received, homebound criteria are met, and an admission visit is completed, a range of services are available to the patient. The most frequently ordered service in home care is nursing. Other disciplines provided by a home care agency may include rehabilitative services, physical, occupational, and speech or language therapy, medical social services, personal care, that is, homemaker and home health aid services, durable medical equipment, respiratory therapy, nutrition education, pharmacy and infusion therapy, and finally, community resources and services. The home care provider may play a single role and may be the only provider of services to the patient. Often, the provider is part of a larger team that works in a collaborative effort to meet the overall needs of a patient in the home. It is often true in home care that teamwork, rather than individual effort, yields the best results in patient care. In addition to offering a variety of services, the home care industry has an array of delivery modes based on their individual business models. A home care agency may often be part of a community hospital system with all the services previously listed available to qualified patients. In some communities, however, it is also common for a single home care agency to represent a particular company, such as an infusion company. This specialized agency will provide its unique service in collaboration with other agencies to meet the needs of a single patient in the home. The nursing care provided may be specialized, such as wound care, enterostomal services, mental health, maternal child health, pediatrics, or infusion therapy. The nursing care may also be generalized. Common nursing diagnoses in home care are need for pain control, medication teaching, and monitoring of signs and symptoms of various medical conditions. In most instances, the registered nurse is the clinician who supervises the patient's care. That nurse may not only provide direct patient care, He or she is integral to the physician in writing a plan of care which may incorporate other disciplines. The goal of all home nursing visits is to provide excellent patient care leading to effective patient outcomes. Care is planned also to foster safety and independence of the patient and caregiver so that the appropriate care will be performed when the nurse is no longer in the home. Licensed vocational or practical nurses may provide direct care within their scope of practice, which varies from state to state, but that care must always be provided under the supervision of a registered nurse.
Good, very good. Okay, now let me check your wrist. Now this bony protrusion, which is your ulnar styloid, should match up to the hand grips. Okay?
Physical therapists teach patients and their caregivers exercise programs that increase patients' strength, balance, and motion. Increasingly, physical therapy in the home is a follow-up to joint replacement surgery and is often a precursor to the patient's transfer to an outpatient setting. Other types of patients, such as stroke victims, Alzheimer's and Parkinson's patients, and para and quadriplegics, are also benefiting from PT at home. In all cases, the goals for the physical therapist in the home is to restore or improve patient function, maximize the patient's level of independence, and ensure the safety of the patient and caregiver at home. PT programs include transfer training, gait and prosthetic training, breathing exercises, assistive ambulatory devices, ultrasound, and electrotherapy. In some home care agencies, physical therapists perform wound care and administer whirlpool treatment. Speech therapists work with patients who have communication needs that have resulted from a physical condition, such as a recent stroke victim with aphasia. Depending on the type and severity of the condition, the treatments address conditions related to voice production, articulation, swallowing disorders, language disorders, and impaired hearing.
Barbara, do you find using the Reacher helpful in
It's
saving
wonderful.
energy?
It sure is.
One thought is to have a Reacher in every room.
Occupational therapists focus on the patient's activities of daily living in a safe and functional environment. To that end, an OT may develop a plan of treatment that involves fine motor coordination, specialized arm and hand exercises, and the use of adaptive and assistive devices. In addition, the OT is able to design, fabricate, and fit orthotic and self-help devices. Examples of the types of patients who benefit from occupational therapy in the home are those with cardiac disease or Parkinson's disease. The skills of medical social workers are required when social-emotional problems exist that directly relate to the patient's medical condition or rate of recovery. Financial, housing, and caregiver concerns are areas covered by social services. Social workers assess the home environment, counsel those involved, arrange for long-term placement, and coordinate and initiate community resources as needed.
Now, I know the therapist is going to be talking to your doctor about getting grab bars in the bathroom. That way it'll be safe for you to get in the bathtub and you can bathe yourself.
Oh, God, I can't wait to take a shower.
Home health aides provide personal care, such as bathing and grooming, or assistance with activities of daily living, such as dressing, feeding, or routine maintenance exercises under the supervision of a registered nurse. Homemaker responsibilities include light housekeeping, meal preparation, personal laundry, and errands. Homemaker services alone are not a Medicare-covered service. Respiratory therapists set up and teach equipment use for treatments that relate to airway management. Their range includes instruction of inhaler use and maintenance of ventilator care. Although the equipment used by the respiratory therapist is reimbursable by Medicare, the actual visit by the therapist is not. Another discipline whose services are not always reimbursable by established insurance programs is the nutritionist. These dietitians are often referred to patients whose nutritional status is less than ideal or need guidance because of a specific condition. They offer dietary instruction to the patient with diabetes, heart disease, ALS, or AIDS, or those being nourished enterally and sometimes parenterally with TPN. Because of the payment issue, the nutritionist's contribution is often provided as a telephone consultation rather than a home visit. The nutritionist may attend team meetings and offer treatment advice at the request of a case manager, and thus may be indirectly involved in patient care. Pharmacists are providers of and the best resource to both nurse and patient for all drugs, both prescribed and over-the-counter. The pharmacist not only dispenses drugs, according to the physician's orders, but is also the expert in reviewing medication doses and regimens, screening interactions of drugs with other drugs or foods. Pharmacists also monitor for therapeutic effects and adverse reactions to drugs, and they recommend changes in the pharmacologic components of the plan of care. Community resources and support groups are frequently a component of home health care. A small sampling includes Meals on Wheels, the Wellness Community, AIDS support groups, and NFCA, or National Family Caregivers Association. The most frequently ordered service in home care is nursing. Other disciplines provided by a home care agency may include rehabilitative services, physical, occupational, and speech or language therapy, medical social services, personal care, that is, homemaker and home health aid services, durable medical equipment, respiratory therapy, nutrition education, pharmacy and infusion therapy, and finally, community resources and services. PT programs include transfer training, gait and prosthetic training, breathing exercises, assistive ambulatory devices, ultrasound, and electrotherapy. In some home care agencies, physical therapists perform wound care and administer whirlpool treatment. Homemaker responsibilities include light housekeeping, meal preparation, personal laundry, and errands. Homemaker services alone are not a Medicare-covered service. The initial interaction between the home health care professional and the patient and/or caregiver lays the foundation for the care to be provided. Professional behavior requires an appreciation of the fact that you are a guest in your patient's home and are providing care by the patient's consent. Respect the impact of what being home means to each patient. Respect the diversity of customs, lifestyles, and even family member interactions. Acknowledge those variations and incorporate their influence into the care you provide. Once again, because of the many variables that are found in the home setting, the rule of thumb remains: prepare for the unexpected. Prior to the implementation of care, consents for treatment are to be signed, advance directives, rights and responsibilities, patient privacy rights, and grievance procedures are addressed. In addition, the provider reviews with the patient and caregiver the limits to the service provided. During the first visit, the home care provider will do a thorough physical exam in accordance with his or her scope of practice. The nurse or therapist must also assess the patient's psychosocial needs, the home environment, and the caregiver support system to determine if additional services are needed to keep the patient in a safe home environment. Once the initial assessment is completed, the provider creates a plan of care in collaboration with the patient and caregiver. Education materials should be also provided on agency services, agency office availability, and emergency preparedness. As part of the overall assessment of the home care patient, at the first visit, the provider will ask a set of mandated questions designed to create a snapshot of the patient at home. This set of questions is called OASIS, or Outcome Assessment Information Set. Required by Medicare on most patients throughout the country, age 18 and over, This information on patient demographics, clinical and functional status, support systems, and activities of daily living are reported by geographic area and submitted to state and federal healthcare regulating agencies as a method of measuring home care patient outcomes. It also contributes to the Medicare payment process under the Federal Home Health Prospective Payment System. Effective April 14, 2003, a patient's right to privacy and security of protected health information, previously an ethical obligation under the Health Insurance Portability and Accountability Act of 1996, HIPAA, became law. To achieve the requirements of HIPAA, during the initial visit, clinicians also must ask the patient to identify the specific individuals with whom protected health information, PHI, may be shared. Obtain agreement regarding leaving copies of medical information in the patient's home, and provide and obtain a signature of receipt of the agency's privacy policies. As in the hospital setting, a physician's order must precede the initiation of and any changes in the treatments and medical care provided. Only authorized employees should take verbal service orders. These orders, created by the doctor, the care to be provided by the various services, and the goals of the care are all combined into a treatment plan called the Plan of Care. The Plan of Care is based on a thorough initial assessment, including the OASIS data, and is often written by the home care provider. Commitment by the patient and caregiver to the Plan of Care is critical to its successful accomplishment. It is essential, therefore, that their needs and requests be included in the plan from the initial visit. Instruction and care included in the initial plan of care are geared towards independence and safety in the home. Assessing for a safe environment is vital, and the need for both patient and provider safety cannot be overemphasized. If a patient is unsafe in the home care provider is obligated to arrange for an environment for the patient where the patient is not at risk for accidental falls, physical or mental abuse, or social isolation. Under certain circumstances, this may mean arranging for the patient to be moved to another level of care, such as an assisted living facility or skilled nursing home. A patient who uses a wheelchair is safer if all doorways permit easy passage of that wheelchair. A patient who is bedbound is safer when smoke detectors have been installed and the caregivers have been taught emergency exit procedures. A patient walking around with an IV pole is not safe if there are scatter or throw rugs all over the home. Educating the caregivers in emergency preparedness and offering recommendations to improve the patient's safety is integral to the initial visit. And safety in home care refers also to the provider's safety. If a provider feels unsafe in a patient's home or neighborhood, he or she should go to a secure environment and immediately contact a supervisor or police if appropriate. Once the plan of care has been created, the provider is responsible for carrying out the orders to achieve the goals agreed upon by the provider, the doctor, and the patient. The plan may call for a team of providers to achieve the stated goals, and so the interaction of team members is critical to the plan of care. While the doctor empowers the team to provide specific treatment modalities, the patient and caregiver are the central members of the health team. Their commitment to the plan of care is among the most important factors in the patient's regaining and maintaining health. With each subsequent home visit, the nurse or therapist must carry out at least one of the following skilled functions as defined by Medicare: assess, teach, perform a skilled need, or manage and evaluate the plan of care. For optimal outcomes, health team members must be consistent in their approach to the patient and caregivers. This is achieved through a variety of means. Communication among team members must be frequent and precise, both oral and in writing. Cell phones, voicemail, and pagers can be very effective information transmitters. Participation in team meetings, case conferences, or teleconferences is vital to achieving supportive, shared, and appropriate care management. And finally, documentation. The clinical chart is the one record that chronicles the patient's course of care, from the initial assessment and subsequent plan to the interventions, the responses, the overall patient outcome, and discharge. Documentation, whether written or computerized, must be comprehensive, precise, and consistent in format. Although we have addressed only the basics, we hope this video has enhanced your knowledge of home health care, the one area of healthcare in which the ultimate and stated goal is to empower the patient or caregiver to achieve, through education, support, and respect, the highest level of independence and well-being. Professional behavior requires an appreciation of the fact that you are a guest in your patient's home and are providing care by the patient's consent. Respect the impact of what being home means to each patient. Respect the diversity of customs, lifestyles, and even family member interactions. Acknowledge those variations and incorporate their influence into the care you provide. Once again, because of the many variables that are found in the home setting, the rule of thumb remains: prepare for the unexpected. These orders, created by the doctor, the care to be provided by the various services, and the goals of the care are all combined into a treatment plan called the Plan of Care. The Plan of Care is based on a thorough initial assessment, including the OASIS data, and is often written by the home care provider. Commitment by the patient and caregiver to the Plan of Care is critical to its successful accomplishment. It is essential, therefore, that their needs and requests be included in the plan from the initial visit. Prior to the implementation of care, consents for treatment are to be signed, advance directives, rights and responsibilities, patient privacy rights, and grievance procedures are addressed. In addition, the provider reviews with the patient and caregiver the limits to the service provided. During the first visit, the home care provider will do a thorough physical exam in accordance with his or her scope of practice. The nurse or therapist must also assess the patient's psychosocial needs, the home environment, and the caregiver's support system to determine if additional services are needed to keep the patient in a safe home environment. Once the initial assessment is completed, the provider creates a plan of care in collaboration with the patient and caregiver. Education materials should be also provided on agency services, agency office availability, and emergency preparedness.